Thank you, Dennis. I'm very fortunate in our group. We have a number of younger investigators who have done very good work. Joel Wells is a resident who recently finished with us and is now in the fellowship at St. Louis with Dr. Closey and Dr. Neppel. Travis Matheny has been in the forefront of looking up our long-term results, and he has been particularly interested in looking at things from a slightly different approach. I'll acknowledge lots of people, a lot of my mentors who are here on this slide. Robert Salter, of course, innovated the whole concept of acetabular redirection, and a number of others on this slide you're recognizing, including Dietrich Tonis and Heinz Wagner and my personal mentor, John Hall, Dr. Harris in the bottom, Reinhold Gans in the anchor group. Then there's the home team, and I've already told you, Dennis has recognized it. We're very fortunate. Dr. Kim Novias, Matheny, Aaron DeWicki, RPA, HIP team physiatrists, the fellows and residents, and our research coordinators. So, of background, of course, we all know that the Bernese periacetabular osteotomy is indeed well-described non-arthroplasty treatment for symptomatic DDH. We've previously reported the midterm outcomes of a large cohort of patients. There are a few long-term studies, more than 15 years. This will be one when we get it published, and of course we're going to hear from Simon Stepacher about the 30-year results. Historically, when people have looked mostly at the native hip survivorship when it fails to total hip replacement. On the other hand, there are hips that don't require total hip or haven't had it yet, but are not particularly well functioning. This is a slide from Christoph Albers' paper in 2013. So the purpose of this particular study was to assess the long-term outcomes of the Bernese PAO in Boston for sure, to determine the predictors of long-term outcomes of conversion to total hip replacement and of a painful symptomatic but preserved hip, and to analyze the quality of life and activity-related outcomes in those preserved hips. This was an IRB-approved retrospective study of the PAOs that I did beginning in 1991 to 1998. Clearly, many of these were not done like I would do them today. This was an early experience, of course. These patients all had symptomatic congruous dysplasia with lateral center edge angle less than 20. They were excluded from the study if they had a PAO for non-DDH deformity, and there were a few of those. And, of course, PAOs done after the cutoff date. This was my first one, and fortunately, it went well. If it hadn't, then my personal history, of course, would have been quite different. But she was a 10-year-old female, 2 years of pain with sports. She had horrific dysplasia, and you wonder, how do we not find these, Stuart? But, they still come along all the time. So she had literally an open reduction. It was really almost dislocated at age 10. Femoral shortening, Dega osteotomy, trochanteric transfer, but it still wasn't quite right there in those two middle slides. Much improved, but the teardrop wasn't quite right. It was still lateralized. She had a lot of radiographic predictors of failure. So this is not my prettiest PAO for sure, but it certainly was my first one, and fortunately without the right tools still it healed well, and she now has 2 children. I saw her about 3 months ago, and indeed now it's almost a 25-year follow-up, and as far as she's concerned, her hip is perfect. So the methods for this study were to use the usual parameters that we all have used in evaluating our patients, including joint congruency by Yuji Yasunaga's classification. And the postoperative outcomes measurements were those we frequently use: UCL activity score, WOMAC, HOOS SF12, modified Harris-Hip score, and EQ-VAS. So looking at the Bern group experience, and again, we're going to hear it updated by Simon, 60% or so at 20 years had not undergone total hip replacement, but of that survivor group, about 20% reported poor or fair outcome scores. Anders Troelsen, looking at Sabali's group, 82% at 9 years had not undergone total hip replacement, but 36% of those that were still functioning had varying degrees of groin pain. So we, in particular, wanted to look at this other group of survivors that were symptomatic. So we asked additional questions. Had they had additional hip surgery? Not only had they been converted to total hip replacement, but what was their level of satisfaction with total hip replacement, and would they make the same decision to undergo a PAO if they had to do it again? So Travis led this and felt that this was a good way to stratify the groups, and we agreed, into asymptomatic preserved hips with a WOMAC pain score less than 10, symptomatic preserved hips with a WOMAC pain score greater than 10 at any time during the post-op period, and replaced hips. Now, WOMAC is interesting because it's sort of a moving target, and I think maybe Travis will want to participate in the discussion, but, some people had a high WOMAC at one point, later on had a lower WOMAC, which was very interesting. So at any rate, we began with 158 dysplastic hips, 37 were lost to follow-up, although I'm finding them as I look for them more. Left us with 121 hips with dysplasia, 26 replaced, 31 symptomatic by our definition, and 64 asymptomatic that had pain score less than 10 and no total hip replacement. So the results, again, 121 available for review. Average follow-up in these patients was minimum 15 years, and maximum now it's 25 years. The average time at the PAO, average age, was about 27. Youngest was 10, that patient you just saw, and the oldest was more than 45. 86 females, the majority, 13 males. 64 hips, again, were asymptomatic and preserved. This was 53%. 26% were symptomatic by our definition and preserved, and 21% had been replaced by total hip replacement. The Kaplan-Meier survivorship curve is this. Basically, with total hip as an endpoint, and remember, we don't think that's necessarily the only endpoint, 74% at 18 years. Of the preserved hips, looking at the symptomatic ones versus the asymptomatic ones, not surprising, the majority of the asymptomatic hips reported a WOMAC score pretty low, 0 or 1, and interestingly, 7 hips that had previously reported pain scores greater than 10 at follow-up reported a WOMAC pain score less than 10. So the pain does not necessarily get worse over time in these patients. Postoperative factors and outcome. Well, the arthrosis looked at by x-ray tended to get worse. It didn't tend to get better. 9 asymptomatic hips had progression of their OA from grade 0 or 1 to 2 or 3. 78% of the symptomatic hips had some progression of their OA, and 5 of the symptomatic hips had progression of their OA from 0 or 1 to 2 or 3. Looked at a little more carefully, univariate analysis, not surprisingly, the replaced hips were significantly older at the time of their PAO surgery than the preserved hips. No surprise. The ROC analysis indicated that age 25 was the best cutoff to maximize sensitivity and specificity to predict the outcome for both replaced hips and symptomatic hips. Preop minimum joint space, preop joint congruency, and tonus grade were all significantly better in preserved hips. No surprise. A multinomial prediction model developed by Travis identified 3 predictors of having a symptomatic or replaced hip: age greater than 25, preop joint space less than 2, or preop poor or fair joint congruence. So this seems to be a pretty busy slide, and it is, but there's a lot of meat in this, and when the article gets published, I think you'll find it useful. This says that a patient that's at most 25 years old at PAO has a good or excellent joint congruence and has a minimum joint space between 2 and 5 millimeters, has an 81% probability of being asymptomatic. It's up there in the upper left. And 15% probability of being symptomatic, and only a 4% probability of the hip being replaced at 18 years of follow-up. In comparison, on the other side of the coin, a patient who's older than 25, has poor or fair joint congruency, has a minimum joint space less than 2, has a 14% probability of being asymptomatic. Not 0, but 14%, 10% probability of being symptomatic, and a 75% probability of being replaced at age 18 years. So there's still a few surprises even with our factors here, but these are basically probabilities. Activity level. The majority of the asymptomatic hips, of course, were very active. 30% of the symptomatic hips also had an UCL activity score greater than 7. What about satisfaction level? Well, 96% of the asymptomatic patients were satisfied with their surgical outcome, and of course I'd hope so. 83% of the symptomatic hips still reported being satisfied with their surgical outcome. And when asked whether they'd undergo a PAO again, 98% of the asymptomatic patients and 87% of the symptomatic patients claimed that they would. Now, we didn't look in detail at the ones who had total joints, but a number of them were very pleased with their PAO even though it had total joints. So in summary, we have 95 hips were preserved and were either asymptomatic or symptomatic. 53% were asymptomatic by our definition, 26% were symptomatic, and 21% had been converted to total hip replacement at an average age of almost 9 years after the PAO. The predictors of asymptomatic or replaced status were age greater than 25, poor or fair pre-op congruence, and pre-op cartilage space less than 2. There are surgeon-controlled factors that are clearly important, but in this analysis, they did not reach the level of statistical significance. So in summary, asymptomatic hips reported significantly better activity and pain-related outcomes compared with symptomatic hips. And the majority of the patients at long-term follow-up have a high level of activity and report a high level of satisfaction with their outcome. And we've developed some predictive factors that can help us in telling patients what to expect after PAO. Thank you very much.